Good morning, everybody, and welcome to the Friday Urology Breakfast Collaborative Teaching. We welcome first off Dr. Alex Spitko, and it's important that we congratulate him from the University of Stellenbosch. He did well in his exams recently and is a fully fledged urological surgeon. Congratulations, Alex, well done. Looking forward to your talk. Do you want to make a start?
Good morning, Prof. Thank you. Thanks for letting me know. Appreciate it. I think let's get going. I hopefully can keep it down to half an hour. If I go too long, please let me know, Prof. So I'll be talking about an approach to azoospermia, which I think it's quite a big topic, but I will try and kind of make it as concise as possible. Just wanted to welcome everybody to the talk this morning. For those who don't know me, I'm Alex Spitko. I'm one of the registrars at Tygerberg at the moment. Let me just see, why is my screen okay? Cool. So in terms of just quick definitions, aspermia being the complete absence of sperm, azoospermia being the complete absence of sperm from semen, and then oligospermia being less than 10 million sperm per mil. In terms of non-obstructive azoospermia and obstructive azoospermia, which is how we break down the classification. Non-obstructive azoospermia will be then due to the absence or marked reduction of sperm production by the testes, whereas obstructive azoospermia will be azoospermia that is due to blockage in the ductal system. So there will be absence of spermatozoa or spermatogenetic cells in semen as well as in post-ejaculate urine, which is important when we get to the workup. So in terms of infertility, about 15% of couples are unable to conceive after a year of unprotected intercourse. Male factors, solely male factors, take about 20% of infertile couples, and contribute to about 30 to 40% of infertile couples, and combined factors. Whereas azoospermia is present in about 15% of infertile men, and of which obstructive is 40% and non-obstructive is about 60% of azoospermia. When breaking down the etiology of azoospermia, one can break it down into or classify it into idiopathic, which is about 10% of all azoospermia, which where the cause is actually unknown, where the semen analysis seems to be normal, but also this is actually infertility, causes, but the semen analysis is normal, but the couple is infertile. In terms of pre-testicular causes, which take up about 5% of cases, they can be either grouped into congenital or acquired, where one could have primary tumors such as prolactinomas, or GnRH mediated causes. So things that, for instance, would stimulate GnRH would be things like melatonin from the pineal gland, or for instance, such as corticotropin releasing hormone, testosterone inhibin that could potentially inhibit your gonadotropin releasing hormone. And then testicular causes, which are about 80% of causes. These can either, again, be divided into congenital causes such as anorchia, testicular dysgenesis syndrome, and genetic abnormalities. Important genetic abnormalities that we take into account are things like Klinefelters, your Y microdeletions, so probably those. And then acquired causes, I break it down into things such as trauma, torsion, and tumors, then inflammatory causes, things like orchitis, nephritis, and hepatitis, varicoceles, and then exogenous causes such as drugs, heat, radiotherapy, chemotherapy and surgery, and then your post-testicular causes, which take up only about 5% of causes, and these can be either congenital, where we look at your congenital bilateral absence of the vas deferens, which we'll discuss a bit about the CFTR gene, your cystic fibrosis transmembrane regulator genes, and then acquired causes such as infection, traumas, and surgery. And then you'll get your obstructive and emission issues, which will then be primarily site-specific. So when one approaches azoospermia, I think the important thing is that most of us will approach infertility patients in the same way. We will take an appropriate history, we'll do an appropriate examination, and then end up doing a semen analysis. And on that semen analysis, we'll identify azoospermia. So just to start off with the general approach, remember it takes two to tango. So there's a male and a female. Make sure that you take an appropriate history and make sure that the female is also evaluated. So look at things like prior pregnancies, prior children with the same partner, with other partners. Look at the sexual history, things such as erectile dysfunction, menses, contraceptives, and libido. One would be very surprised, even higher functioning patients seem to do things that will sometimes dumbfound you, like use condoms but still try to fall pregnant. So medical history as well. Remember to look at what drugs they're taking, any comorbidities. Do they have a poor general medical state? Are they poorly controlled? Diabetics, for instance, have they undergone any chemotherapy in the past? Even childhood chemotherapy. Do they have any prior infections, specifically things like viral otitis, so things like mumps, TB, sexually transmitted infections? Have they had any prior surgery? So retroperitoneal lymph node dissections, we know will have emission issues or retrograde ejaculation or anejaculation. There might be patients who've had previous pelvic surgery, patients who've undergone for incontinence and BPH surgery, as well as those having primary surgical scrotal surgery. On history, one must also take into account occupational factors. So specifically patients who have very high stress jobs, maybe very sedentary jobs, or have extensive chemical exposure in their occupations, or needs to take into account potentially that as a risk factors. And then on social history, look at things such as smoking, alcohol use, recreational drugs. Are they exercising? Do they do extreme dieting or extreme weight loss, or do they have very poor habits, eating habits, and result in obesity? And then also make sure that you've taken an appropriate family history or genetic history. See if there's any history of fertility, subfertility, or infertility in the family. So remember to perform an appropriate clinical examination of the patient. This means that a good general examination. Some of the things that we need to look at are obviously your endocrine evaluation. So look at the patient's eyes, look at the patient's neck, evaluate whether or not they have a goiter or a thyroid mass, look at whether or not there's any gynecomastia. Secondary sexual characteristics are also very important. Do a Tanner staging if it's appropriate. And then obviously get to your genital examination. And how I break it up is basically into the different components of the male examination. So look at the penis. Are there any anatomical abnormalities? Are there any strictures that are palpable? Maybe a curvature, maybe a Peyronie's plaque. The testes. Look at the size, the symmetry, the consistency. Are they both present? Are there any sinuses on the scrotum that could be potentially something like TB? Look at the epididymis. Is it present? Are there any masses or nodules? Is it full? Is it quite tender? The vas deferens is obviously the one that's also very important when we're looking at especially obstructive azoospermia. And that will be then obviously any defects, any nodularity, or swelling or induration of the skin around the vas deferens is something that you must take into account. Spermatic cord evaluation is important, looking at things like varicocele, and then finally getting to the digital rectal exam, where you should evaluate prostate for any kind of firmness, any masses or any abnormalities, and then seminal vesicles. If you can feel them, they might be overly full. It just gives you an idea of evaluation of the patient. So I think the crux of the matter is to get to the semen analysis, and this is a table from the new EAU guidelines that I got comparing the 2010 WHO low reference limit for normal semen analyses to the new 2021 one, which is now from the 6th edition, I think. And as you can see, the majority of the figures are actually quite similar, maybe a few percentage points up and down, maybe 0.1, 0.2 mils difference, or it's not really that significantly different from what I could see. But the big thing was the antibody testing has kind of been shoved out the door at the moment. It looks like it's not really as popular as maybe it was before. And one of the things that I found interesting was now the measurement of sperm DNA fragmentation index. And what I like about this is it makes it more almost individualized, where semen analysis can't really tell between, can obviously give you figures with regards to the patient's semen, but will not give you an indication of specific sperm fertility potential, if that makes sense. So DNA damage might like occurs in sperm that are in patients who are infertile, and the DNA fragmentation index looks at the amount of single and double strand DNA breaks, and if these DNA breaks are increased, then the likelihood for like normal conception is limited. So one would then potentially look at things such as ICSI and assisted reproduction. So remember just things about the semen analysis: 1 to 3 days of abstinence, ideally no condoms unless one has to use a condom or intercourse. Masturbation is contraindicated for some reason, and one can use specific condoms that are used for these semen specimens. Avoid lubricants and spermicides. Make sure that you have clean hands and a clean penis in a sterile container. Make sure it's kept warm, ideally at body temperature, and it should be dropped off within 30 minutes of the laboratory. Some of the specific things that, and this is mentioned again in the EAU guidelines, is with regards to azoospermia, is that the semen analysis may actually have a normal ejaculate volume when there's azoospermia after centrifugation. So there is specific methods that use for azoospermia itself. So if they find azoospermia, then the semen is then centrifuged at about 3,000 G for about 15 minutes. And then a microscope is used to examine at about 200% magnification of that centrifuged pellet. And then all these samples are stained and re-examined again. And the reason is because even if you find a very small amount of sperm that is potentially usable, one can then either cryopreserve it or use it for ICSI. So once you have confirmed azoospermia, the next step is then to look for the presence of a vas deferens. If the vas deferens is absent bilaterally, then one would do CTFR gene testing. So that's cystic fibrosis transmembrane CFTR, sorry, cystic fibrosis transmembrane regulatory gene testing. And we'll go at a later stage a little bit more into depth about this, but then the options in these patients are sperm retrieval and assisted reproduction with genetic screening as well as adoption. But if you check for the vas deferens and it is present, then the next step is then to look at the semen volume. And if that semen volume is low, then the next step would be to look at a post-ejaculatory urine analysis. I know that I think the old EAU guidelines, they didn't have this step within them, and I'm not even sure, I don't see this actually in the new one, but I like to approach it this way because you can exclude then something like retrograde ejaculation in the patient. So if post-ejaculatory urine analysis is positive for sperm, there's actually it's retrograde ejaculation. And how this is done is the patient's urine is about alkalinized for about 24 hours. At the morning of the specimen, the bladder is emptied and then washed out with Ringer's glucose solution, and about 2 ml of that solution is left in the bladder. The patient is asked then to masturbate, and then that ejaculate that is then urinated out is then evaluated for semen. And if there is for sperm, and if there's sperm, then we know that it's retrograde. If though the urine analysis shows that there's no sperm, one will then do a transrectal ultrasound looking at the size of the seminal vesicles. If the seminal vesicles look normal, then we are more inclined to think it's an emissary issue. However, if the seminal vesicles are increased in size, then one could potentially do, so not everybody does this, but one could do a seminal vesicle aspiration. And if there's no sperm in the seminal vesicle aspiration, then you know that this is likely a more proximal issue. So it's more vasal epididymal obstruction. Whereas if there is sperm in the seminal vesicle, then we know this is definitely ejaculatory duct obstruction. So when looking at obstructive azoospermia, it's divided into intratesticular obstruction, epididymal obstruction, vasal obstruction, and ejaculatory duct obstruction. And each one actually has a congenital and an acquired cause for each one. And we'll go into a bit more detail during the talk. But in terms of intratesticular obstruction, the congenital cause is actually a disjunction between the retitestes and the efferent ductules. So it isn't an appropriate drainage, and there's obviously obstruction. And then acquired causes, so anything that can cause inflammatory or traumatic changes to the testes can result in intratesticular obstruction. In terms of epididymal obstruction, so here there's a kind of either idiopathic epididymal obstruction, where the epididymis is detached from the testes in some of these mal-descended testes, or there's an acquired cause. And again, this is either epididymal or post-surgical. And I think this is something we always counsel our patients when we do epididymal cyst excisions for, is that there's always a risk for post-surgical epididymal obstruction. In terms of the vas deferens obstruction, then again, here we get your congenital bilateral absence of the vas deferens, and acquired. I think the most common ones are then either the post-vasectomy ones, as well as post-inguinal hernia repair surgeries, specifically, I think, with the polypropylene mesh that one gets. And then ejaculatory duct obstructions, and we'll talk a bit about prostatic cysts and pelvic cysts in males, and then your acquired ones, which most of the time are either as a result of post-surgical or post-infective causes. So when one looks at congenital epididymal obstruction, it's the most common cause of obstructive azoospermia so about 30 to 60% of azoospermic men with normal FSH levels that are less than 2 times the upper limit of normal. Usually it actually manifests as a kind of congenital bilateral absence of the vas deferens, and at least 80% of these patients actually have a mutation, at least one mutation in the cystic fibrosis gene. It's associated also with absence of the distal part of the epididymis, as well as seminal vesicle agenesis. So when one does feel this abnormality in the epididymis, and you do as a transrectal ultrasound, you might actually only find one seminal vesicle. So some of the other congenital forms of epididymal obstruction, this will be things such as chronic sinopulmonary infections, so Young syndrome, where there's mechanical blockage because of debris in the epididymal lumen, or there can be a disjunction between the efferent ductules and the corpus epididymis, and then there can also be just an agenesis or atretic portion of the epididymis. And then acquired ones, I think the most common that we get exposed to are either acute, so gonococcal and subclinical epididymitis, which will be more your chlamydia, but any kind of acute or chronic trauma can also result in epididymal damage, and any kind of epididymal surgery can definitely result in azoospermia, but usually it's unilateral, so it shouldn't be azoospermia. So congenital vas deferens obstruction. So the most common congenital vasal obstruction is the congenital bilateral vas deferens obstruction, and this is accompanied by the cystic fibrosis gene mutation. Unilateral agenesis is almost like a partial defect, and it's associated with seminal duct abnormalities and renal agenesis. So in these patients, one must always remember, if you've got unilateral agenesis of the vas deferens, one must look at the kidney, and you can do an abdominal ultrasound. And there is an embryological association, as it's a Wolffian duct remnant between the vasa and the seminal vesicles. So most patients with vasal agenesis will then also have hyperplasia or agenesis of the seminal vesicles. And all of these patients should have low semen volume, because we know that the largest component of semen is actually comes from the seminal vesicles. If there's seminal vesicles or unilateral, if there's unilateral agenesis, as I mentioned, the important thing is to look at the upper tracts, but also then looking at the vas deferens and seminal vesicles on that same side. Especially if you have azoospermia that's looking at, then you must also look at the contralateral side. So in terms of acquired causes, so the most common acquired cause is then following vasectomy. One can also actually then get it post-vasovasostomy. So because about 5 to 10% of patients with epididymal blockage will have a tubule rupture. Vasal obstruction can also occur after a herniatomy and even after herniorrhaphy with polypropylene mesh, and that's primarily because it induces quite a large fibroblastic response. So there's a fibrotic plaque around the vas deferens, and it kind of causes a stricture or an obliteration of the vas deferens. Some of the congenital ejaculatory duct obstruction causes, so these will be those cystic structures. So the ones that I think we deal with the most common are then either your medial cysts or your prostatic utricle cysts that can be quite large, or your Mullerian duct remnant cysts, and then your paramedian cysts, which are your ejaculatory duct cysts. The kind of the more lateral cysts, I think, are a lot more uncommon, as well as your extraprostatic cysts. They're quite rare. I've actually never seen seminal vesicles or cysts of the vas deferens, but there are things that you need to take into account as potential causes for ejaculatory duct obstruction. And then acquired ejaculatory duct obstruction. This again, most of the time is post-inflammatory and can be as a result of acute or non-acute chronic prostatourethritis or prostatitis. And this is usually associated then with a low semen volume because your seminal vesicles are obstructed. There's a decrease in absent seminal fructose, and because of your prostate is kind of the PAP, your prostatic acid phosphatase, is contributing to this more acidic pH. These are things that could be indicative of ejaculatory duct obstruction. And also on transrectal ultrasound, your seminal vesicles usually be nice and big and dilated. So the AP diameter should be more than 15 millimeters. You do get a functional obstruction of the distal seminal vesicles, seminal ducts, and this is hypothesized to be as a result of a local neuropathy. So there's usually a adynamic segment almost. So either there's pilovesicular atony, or there's a very hypertonic ejaculatory duct. So it's literally occluding the outflow of the seminal vesicles and the ejaculatory duct. And this has been shown to be associated with either juvenile diabetes mellitus as well as polycystic kidney disease. So further workup in patients with we'll be then looking at patients' hormonal profiles. One would then look at in these patients, they should have normal gonadotropin releasing hormone as well as androgens. Serum FSH normals can be normal and does not exclude a testicular cause of azoospermia, because in about 40% of these men, the FSH levels are actually normal in about 40% of men with primary spermatogenic failure. So there has been a kind of a move to use inhibin B as a marker, as it seems to have a more or a high predictive value for normal spermatogenesis. And then genetic testing should be done in patients with bilateral agenesis of the vas deferens. And this is looking for that transmembrane conductance regulator mutation, gene mutation. And then remember, in terms of this kind of cystic fibrosis gene, the female partners should also be tested as potential carriers before using that patient's sperm, a man who has the gene mutation in a female who is a potential carrier. Imaging modalities, again, scrotal ultrasound, you want to look at features of obstruction. So there might be a dilatation of the reti testes. I think I've got a nice picture in the next slide. There might be an enlarged epididymis or cyst or an absent vas deferens on the scrotal ultrasound. If you've got testicular dysgenesis syndrome, there might be kind of an inhomogeneous testicular architecture with microcalcifications, and also important to measure testicular volume and size. Abdominal ultrasound, again, unilateral vasogenesis, looking at the ipsilateral renal anomalies, and then transrectal ultrasound, so looking at seminal vesicle enlargement and any kind of round anechoic areas in the seminal vesicles. And this can be used at the same time to perform seminal vesicle aspirations. And if there are more than 3 sperm per high power field, then this is supportive of ejaculatory duct obstruction. And you could look for any kind of pelvic cyst or prostatic cyst that might be causing your obstruction. So here's just some imaging. That first picture on the left, that'll be your your retitestis cysts, then your microcalcifications in the top right corner, and then this is just a nice picture of a transrectal ultrasound of some bulky seminal vesicles. Seminal vesiculography. So I think this is mostly used in patients where the anatomy of the seminal vesicles and ejaculatory ducts you try to identify them, but I think the primary method is seminal vesicle chromotubation, and that is used at the same time where you are highly suggestive of ejaculatory duct obstruction, and you want to actually perform a transurethral resection of the ejaculatory ducts at the same setting. So this is where either indigo carmine or methylene blue is then injected directly into the seminal vesicles transrectally. And then a cystoscopy is performed, and if you can see that indigo carmine actually draining into the urethra, then you know that there isn't any obstruction. But if you can't, and it's usually nice and big and bulging, then you can perform a transurethral resection of the ejaculatory duct, and that should help with. Then once you see the blue draining, you know that you've opened up the ejaculatory ducts. So vasography. So the absolute indications of this are azoospermia, but also if the patient has complete spermatogenesis with many mature spermatids on the testis biopsy and at least one palpable vas deferens. And then relative indications will be patients who have got severe oligospermia and normal testis biopsies, or patients who have a lot of high level of sperm-bound antibodies that may be due to obstruction, or if the patient's got a low semen volume and poor sperm motility, that it could be like a partial ejaculatory duct obstruction. All right, so here it's more looking. I think I'm running a bit out of time, so I'm going to just jump through that slide there. But this is just how the vasography is performed. So an incision is made on the scrotum, or highly on the scrotum. The vas deferens is identified, cannulated, and at the same setting, then a transurethral catheter is inserted, and the balloon is filled with 5 mL of air. And then the catheter balloon is actually put on traction, and that just prevents contrast refluxing into the bladder. And then your contrast is then usually what happens is that first the fluid is aspirated, and then ringers can be injected into the ringers lactate can be injected into the vas. And if it drains very easily, then usually you know there's no obstruction, but you can confirm this then with contrast media. So again, this is very much, apologies for the slide, I think it moved a bit, but if what one finds is, for instance, an epididymal obstruction, you could find that the vasogram usually shows is patent, and the vasal fluid will be absent of any sperm. So then you know that this is most likely then epididymal obstruction. You can do then either usually then a vasoepididymostomy. In retrograde ejaculation or lack of emission, the vasogram will be normal, and there will be many normal sperm on the vasal fluid. And then the vas deferens obstruction, ejaculatory duct obstruction, the motile sperm are actually found in the vas. So what one can do here is barbotage the actual testicular end of the fluid, and then you can send that for cryopreservation, and then inject ringers lactase distally to make sure that it's patent. This actually can confirm patency, or you can actually inject indigo carmine and do a cystoscopy at the same setting, or a vasogram. And then depending on the site, depending what the cause was, one can do a vasovasostomy. But this procedure is not without its complications. They're very small lumens, so things like strictures, ischemia of the vas. One must be very careful about not damaging the vascular supply. In the adventitial layer there, hematomas and sperm granulomas are also potentially a problem. Testis biopsies. These will distinguish between obstructive and non-obstructive causes of azoospermia. So indications will be normal testicular size and consistency. If one has a palpable vas deferens, at least one palpable vas deferens with a normal FSH level, and diagnostic biopsy should be done bilaterally. So this will be irrespective of size discrepancy. And then one can also do therapeutic ones where one will harvest sperm with intention for use in ICSI, especially in azoospermia. So here we can see the testis biopsy. Usually a single incision is made, ideally polar, where a pea-sized area of seminiferous tubules are taken out. About a 4 mm incision is made, and a pea-sized area of seminiferous tubules are taken out and sent for evaluation. And then the tunica albuginea is closed. And here we just have an example of a percutaneous testicular biopsy. So some of the sperm retrieval techniques, just quickly, one gets testicular and then epididymal sperm extraction techniques. So those will be TESI, TESA, and TEFNA. I think in general, testicular sperm extraction and testicular sperm aspiration are used most commonly. And then epididymal then will be your, and then microtesi as well. And then epididymal will be the microsurgical epididymal sperm aspirations, that's MESA, or percutaneous epididymal sperm extraction, which is PESA, and then SE, which is epididymal sperm extraction, which is usually open. The indications for tesi and microtesi, so this is where you don't find sperm in the epididymis in the presence of spermatogenesis, or if there's complete absence of the epididymis, or in patients who've got non-obstructive azoospermia, which is whereas tesa is more in patients who've got normal spermatogenesis with obstructive azoospermia. So you can retrieve quite a large amount of sperm in a small amount of tissue. And then epididymal extraction will be indications will be things like congenital bilateral absence of the vas deferens, or unreconstructible obstructions, or patients at the time of vasoepidermostomy, one can retrieve sperm and then perform this epididymal extraction techniques. So there are some advantages and disadvantages to each technique. I don't think I have enough time to go through all of them. I apologize. And then these are just some examples of how each one is performed. When one looks at just some of the treatment options quickly, so intratesticular options will be tesi, so one can just retrieve sperm in almost all obstructive azoospermia patients, and then those are then either sent for cryopreservation or ICSI, and then epididymal obstruction will then either be managed with sperm extraction. So this is either done with MESA in patients with congenital bilateral absence of vas deferens, or one can use TESA or PESA, and then these are all sent for the ICSI ideally. Or in the epididymal obstruction, one can do microsurgical vasoepidermostomy. And this is usually indicated for patients with obstructive azoospermia due to this acquired epididymal obstruction. And this is just a quick slide on this vasoepidermostomy technique, with just remembering to intercept your sutures, ideally to keep the lumen patent. If the vas deferens is obstructed, then gold standard is in microsurgical vasovasostomy. It's also dependent on the site of the vas obstructions. One can do multiple different techniques for vasotubulostomies and so forth. Depending on the site. Ejaculatory duct obstruction, so one can do sperm retrieval techniques that we've discussed. If this is a cyst is obstructing, then one can do either cyst deroofing or incision of that cyst. This can be either done usually transurethral with intraoperative truss, just to identify your anatomy, and then transurethral resection of the ejaculatory duct. So this is where, again, I mentioned injection of the indigo carmine into the seminal vesicles, again, transrectal ultrasound guided, and a scope is passed. Identify your openings of your ejaculatory duct, or where you would suspect them. And then once you start incising, one should have this kind of gush of blue coming out if you've actually made those ejaculatory ducts patent. I'm not sure if I have enough time, but let's keep going.
We're probably running a little bit out of time. Maybe you can just wrap up your comments.
Sure. Yeah. So unfortunately, I haven't managed to get through a non-obstructive azoospermia, but this would be my approach then. If one has normal vas deferens bilaterally and normal semen volume, then one would look at the testicular size. And if it's a small testicle, one would then do an FSH. If it's very small, then you would think hypogonadotropic hypogonadism. It's a really good video with Dr. Hook and Dr. Kruger did earlier in the year that discussed hypogonadism. So it's a good one to go and watch. I think it's on YouTube. And then if the FSH is high, then one can look at, then one thinks it's primary testicular failure. And then if you're looking at the testis size and it's normal, again, one can look at your FSH. If it's normal, then one should do a testis biopsy, as well as karyotyping and genetic testing, and looking for spermatogenesis. If those are all normal, then you should manage it as an obstructive azoospermia. However, if the FSH is high, then again, you're thinking it's primary testicular failure. Yeah, I think maybe, yeah. So just the general workup, I'll quickly go through. So one should do a hormonal panel on these patients, so FSH, LH, testosterone, prolactin, and inhibin B. Genetic paneling, so karyotyping and Y microdeletions, and then urine analysis for post-ejaculatory urine analysis. and consider testis biopsy and sperm retrieval techniques depending on what your cause is. And just a quick general management measures. None of these and in the EAU guidelines show very strong evidence, but things such as weight loss, exercise, stop smoking, stop illicit drug use, use alcohol moderation, decrease stress, avoid kind of long distance riding with that kind of perennial pressure. And then things like over-the-counter drugs, your antioxidants such as ubiquinol, coenzyme Q10 have been used. But I think, Prof, yeah, it's difficult. So I think I've got like about a few more slides, but I think my time is probably up. I do have a bad a reputation for going over time with these things, unfortunately.
Alex, superb talk, well illustrated and put together. I was very impressed with the earlier algorithms that you had, for example, to look at starting off with a VAS, whether it's present or not, and then going on to the volume as indicative of taking you down the road of diagnostic workup. Where did you get those algorithms? Are they?
Prof, I used the EAU guidelines and the AUA algorithms also are quite similar, but I kind of made it myself when I was studying. But there might be algorithms like that out there, but they're not exactly the same as the one that I did here. But yeah, I know I used the EAU guidelines and the AUA guidelines, and there's an article from 2008. I just can't remember which journal at the moment, Prof. I'll send you the reference if it's just somewhere on my laptop.
No, very impressive, Alex. I mean, to be able to synthesize it and to produce something that makes sense for you, I think that's a very laudable effort there. Thank you. University of Stellenbosch is obviously famous for the Kruger strict criteria. Do you know the history of that, and is it still used at Tygerberg?
Prof, I don't know I know that they've spoken about it before, but I think it's the Prof Kruger who had the fertility clinic at Tygerberg. I think, but I don't really know the history behind it. That will help, Prof. Sorry, I should. I think my Prof will probably upset about that.
Fair enough. I mean, I believe he was an obstetrician, not a urologist, and it's astounding that those criteria are still often quoted internationally. So something that
it's in the EAU guidelines, probably. So.
Yes, exactly. I see there's one question. Let's just check on that for you. How does nephritis cause infertility, and which particular nephritis should we worry about? You obviously mentioned that earlier in your talk.
Yes, Prof. I must be honest, I'm not sure. I don't want to lie to you. I don't want to lie to people out there. I just know that I have that algorithm in my head that like hepatitis and nephritis can result in infertility. But I know that patients who are on the chronic renal program, patients who are undergoing hemodialysis, and obviously patients on immunosuppressive drugs, they're all at high risk for having infertility. But I'm not sure with regards to which specific nephritis. I don't know. I'm not sure, Prof. I'm not sure if Prof maybe knows.
Okay. Alex, I don't see any further questions, and we're a little over time. I just want to formally apologize for my bluffs earlier. I didn't think through my comments, so apologize to your colleagues there who we're speaking about your exam, etc. But let's move on. We're going to have Dr. K. Kadhi